Hey everyone. So I wanted to do just a quick little lecture on documenting the OT process. Up until now, we've really focused on the evaluation. So how to understand everything that you observe from your or the information you've gathered from the occupational profile, the information that you gathered from your occupation-based performance analysis, your activity analysis, and how you then articulate that into your evaluation. So, and using OTPF language. So for example, we've talked extensively about, vision, cognition, fine motor, gross motor, range of motion, manual muscle testing, balance, posture, functional mobility, ADLs. You've evaluated all of that, and then using OTPF language, how do you then put that into your evaluation with clear examples of what the deficit areas are? So you've observed upper body dressing, and through that, you observed and have assessed that they have deficits in vision, left upper extremity motor control, a 1+ on spasticity, impaired attention and problem solving, impairments in balance. Now, through your specific examples of why those are deficit areas, as noted at the edge of the bed, patient with loss of balance towards the left when donning a shirt. When donning a shirt, noted decreased scanning past midline to identify left armhole. While donning a shirt, client required max verbal multimodal cues to attend to task. Client required max assist to don a shirt while seated at edge of bed, secondary to impaired cognition, impaired attention, impaired problem solving, impaired scanning to the left. So now you've learned how to articulate that using your OTPF language. Now let's talk a little bit more about what a SOAP note is. A SOAP note, in its essence, is every single document you will ever write, this format. So a SOAP note this format is your evaluation. A SOAP note is after you've completed a treatment session, this is what you document that you've done. This is a discharge summary. A SOAP note is used across the continuum of healthcare. It is the format that all healthcare practitioners use to document within a healthcare record. It is a documentation of a client interaction, and that interaction, evaluation, treatment, discharge. So let's break the SOAP note down a little bit more into its components. So the subjective portion, this is a direct quote from your client. This is subjective information that you've obtained from the client. How are they feeling? How are they feeling about their progress? How do they feel about their limitations? What do they report limitations are? What do they report concerns or problems are? What do they want to work on? What is impacting their ability to engage in the therapeutic interaction? It's a direct quote. I have a headache. I am thirsty and need a sip of my coffee before I can continue doing therapy. Your client is nonverbal. What observations are you making of the client that is directly related to the therapeutic intervention? Client appears to be resting comfortably in bed prior to session. Client became restless when therapist introduced therapeutic intervention, whatever that is. So it is a direct quote or an observation of in the moment that you're doing that therapeutic intervention with the client, directly related to the therapeutic intervention with the client. And then your objective is all of the information that you gathered about that client that is measurable, quantifiable, observable. This is your evaluation, right? So this is all of the assessments that you've done with the client. This is everything that you've done in a treatment session. It's exactly what you did with the client, and it must include assistance levels. So from an evaluation perspective, this is your observations and evaluation of the client. In your treatment session, this is exactly what you've done with the client. Oops. And then your assessment is tying everything up into a nice, tidy little bow and synthesizing what it actually means. And this really is to justify our OT services. So this is your appraisal of their progress. This is where they're still having problems, and this is where you're going to document the potential for continued OT intervention. Why do they need you? So in your evaluation, in that objective portion, you described what all their limitations are, and now in your assessment, you're tying it all up. Client presents with A, B, C, D, E, F, however many things, and this is why they need occupational therapy to address, all of these areas in preparation for that safe discharge to the next level of care. So this is why they need you, and this is how you take all of that information that is just like a lot of stuff, and then why they need to continue to see you. In your treatment session that you've just described, 30-minute, 60-minute, 90-minute treatment session with the client, and now you've wrapped it all up. What does it actually mean? Where do they, so we worked on ADLs. They presented this way, and then in your assessment, you just wrap it all up. The client still demonstrates impairments with A, B, and C, and that is why they still need to continue with OT services. And then the plan is how long you're going to be seeing this person and what you're going to be working on. And they need to directly relate back to O and A. If you do not include self-feeding, let's say, in your O and your A, then you're not going to put that in your plan because you didn't say it was a problem. So it needs to directly relate back to that O and the A. So this will be your anticipated frequency and duration. So, and this must include minutes. So, for example, in acute care in the hospital, you might see a client for 30 minutes, 3 times a week for 1 week, knowing that in acute care, you're not going to be seeing them for very long because they'll be going to the transitioning somewhere else. In acute inpatient rehab, you might see them 60 minutes, 5 times a week for 2 weeks. In subacute, where the inpatient rehab, but subacute, where the intensity is not quite so high, you might see them 60 minutes, 3 times a week for 3 weeks. Outpatient, you might see them 1 to 2 times a week for 60 minutes for 6 weeks. School systems is going to look a little bit different. You might see them 30 to 60 minutes 1 time a week, depending on the needs of the child, 1 time a month, quarterly, or on a consultative basis. So that will, potentially look a little bit different, or not potentially, it will look a little bit different for school-based interventions or settings. So what might a SOAP note look like? This should be familiar to you. This was kind of a wrap-up of an ADL evaluation. So the client reported they had a headache. And then they participated in a 30-minute functional ADL eval. They performed upper body and lower body bathing at seated level. Remember, position is so important, with MinAssist for threading bilateral lower extremities into the pants, contact guard with standing balance during clothing management. They required supervision to don the shirt seated at the edge of the bed. They performed grooming standing sink side with right upper extremity support on the sink for balance and contact guard assist for standing. Notice I was very specific with the position and what these strategies they needed to use for their safety. So now when I write my goals, I can really be very specific with my goals because I was very specific with my documentation. So I have a lot to work on now. We can work on, it was bathing at seated level. Now So bathing at seated level, so we can work on standing. Lower body dressing, they needed mini-assist for threading their pants over their feet. And they needed contact guard with the standing balance for clothing management. So I have so many things that we can work on right there. Standing sink side to do grooming, they needed to put their hand on the sink for balance. Well, now we can continue to work on removing that upper extremity support with during a balance task or during grooming, and to upgrade the activity. My assessment was that they have decreased standing balance and endurance during ADLs, which is affecting their performance, and that they will continue to benefit from intensive therapy to address those areas 5 times a week for 2 weeks for 60 minutes in preparation for them going home. So it's very specific about what they are able to do, what their limitations are, what the plan, how you've wrapped it up, and what the plan is for this client. So that is your documentation. Now, goal writing. Goal writing, I mean, I should have said this at the beginning. Documentation is an art. It is a skill. It takes practice. It takes time and effort to learn how to do it and how to do it well. It takes time and effort to learn how to be concise, yet have all of the information in your documentation, to come up with the right words, to use OTPF language. It takes practice. But so your documentation book will have lots of examples of how to write a SOAP note and how to learn how to write a SOAP note. In your documentation class in your final semester, you'll really learn how to do documentation really well. In your book, it uses the COAST method for goal writing, which is relatively similar to the SMART format, but the SMART format is the preferred method that we use for our program because that is the preferred method for the NBCOT exam. So your SMART format is that it is specific, significant, simple. It is measurable. It is achievable. It's directly related to their goals, and it's a realistic goal, and it has a time frame attached to it. So it needs to be significant, simple, and it needs to be specific. What is it that you are directly working on? Addressing range of motion and manual muscle testing is not specific. It's not simple. It is very hard to measure progress in those areas. So you really need to relate everything back to function. What is the functional component that you need to address that will then address range of motion and manual muscle testing? And then how will you measure progress? So you need to use your min, your mod, your max. This is where you use your cues. So client will perform upper body dressing with min assist and min verbal cues to thread left upper extremity into shirt. So it is simple, it is specific, and it's measurable. But it also needs to be achievable. So I need to understand what the deficits of the client are and then make this goal realistic and achievable to the client. The long-term goals and the short-term goals need to be related to each other. The long-term goals and the short-term goals need to be related to each other. I'm going to repeat myself one more time. The long-term goals and the short-term goals need to be related to each other. You cannot have a long-term goal that addresses upper body dressing and have a short-term goal that is a transfer goal. They are not related. I can have a long-term goal of upper body dressing and a short-term goal that breaks down the components that are hard for me to do. So that's my activity analysis right there. Upper body dressing is hard for me to do. That's my long-term goal, to be able to do it. My short-term goals directly address that long-term goal. I can't thread my arm into the sleeve. I can't attend to the left. I can't orient the shirt correctly to even begin the task. Those are the goals. Those are my short-term goals that will directly address the long-term goal for the client to ultimately meet the goal. And then the goal needs to be time framed. Setting a time frame and a realistic time frame is really hard. So I really encourage you to go to your Pedretti. We talked about the page in class the other day, and now I've forgotten to look it up, but there's a chart that talks about the different levels of care and about how long that client will be in those different levels of care. So for example, if you're in the acute hospital, you know that they're going to be there probably 3 to 5 to 7 days, not very long. So you're not going to write a goal that is 2 weeks long. It's going to be a very short little goal. In rehab, in the acute rehab, you might find that the length of stay is 2 to 3 weeks. So your long-term goal might be 3 weeks, but your short-term goals are going to be for 1 week. So being very clear and realistic with those time frames as well. So to recap, short-term goals address the long-term goals. The goals must be functional and client-centered. Range of motion and strength, not appropriate goals. And activities are not goals. So I'm not going to write a goal for therapy because that's an activity. And I could say the same thing for range of motion and strength. Those are activities, those are not goals. I'm not going to write a goal for pinching pennies because that's an activity, it's not a goal. The actual task is fine motor coordination. And then how do I relate that directly back to function and it being a client-centered goal? If you ask a client to button a shirt as an activity, and they say, I don't wear button-up shirts, and you're like, well, I'm going to do this activity anyway because it's good for fine motor coordination. And then you write a goal for buttoning a shirt, that is not client-centered and it's not functional. So just be mindful of what is valuable to the client, what do they want to work on, and then how you also write that goal. So goals, client will perform lower body. I apparently did not proofread my goals or anything when I wrote my PowerPoint. I apologize for that. Client will perform lower body dressing at seated level, standing for clothing management with upper extremity support with modified independence within 2 weeks. My short-term goal directly related to my long-term goal, client will thread right lower extremity into pants with supervision using adaptive equipment at seated level. I should be more clear, adaptive equipment being a reacher at seated level, min-Q for technique within 1 week. So let's talk about an intervention plan versus your treatment plan, and then what is a treatment plan. The treatment plan directly addresses what your goals are. So they always have to be linked back to your goals. Intervention plan is the whole OT process from top to bottom. It's your evaluation, it is the treatment sessions, and it's your outcomes, which is your discharge. A treatment plan is what you do with the client for them to meet their goals. And that is that time framed 30 to 60 to 90 minutes, 15 to 30 to 60 to 90 minutes that you're working directly with the client for them to meet their goals. So treatment planning. It needs to be client-centered. So let's go back to the example of buttoning buttons. If your client doesn't wear button-downs, and you introduce a shirt for them to practice fine motor coordination on, and it's a shirt with buttons, it's reasonable that there are 100 other activities that you could choose that would address fine motor coordination that do not have buttons. So just so that it's meaningful to the client. So when you're selecting what you want them to, what you want to address in a session, what do you want the client to be able to do? What keeps them from being able to do that thing? What are the possible options for them being able to accomplish whatever the goal is? And then what activities will address that goal? So you want them to be able to do lower body dressing. What keeps them from being able to do that? Weakness, balance, attention, vision. How do I improve those areas? What things do I need to work on? Strengthening, balance reactions, maybe there's fear of falling. So those are the things that I need to work on. Now, what activities can I create that will then address those areas? Always remember therapeutic use of self. Like, let's say for the example of fear of falling, if my client is sitting at the edge of the bed and they are so scared that they're going to fall with the activity that you've introduced to them, how do I use myself to create confidence in them for them to be able to engage in the activity? So when you're thinking of again, this treatment sessions and how you create them, remember the occupations, those are just the broad daily life events that we do. And then the activities are the components of the occupation. So I apologize. So when you are creating your treatment session, the occupation is lower body dressing. And then the activities are the components that go into that to address the lower body dressing. And my recommendation to you all is get in the habit of planning your session out with realistic timeframes. So if I'm thinking lower body dressing, and I'm like, let's do lower body dressing for 30 minutes. How do you know that's going to take 30 minutes? And what are the things that you're going to do within that 30 minutes to address that goal? So it could be that you start with a warm-up of core strengthening stability work, and then you have them practice crossing midline and attention, and then you actually give them the pants to help work, and then maybe you do some stretches for external rotation because they're stiff, and then you give them the pants, and then you transition into working on balance activities, but breaking those down into the little components so that you know how to maximize that time with the client. This is a toughie, but think bottom up versus top down. And this goes for your evaluation. This goes for your treatment sessions. Bottom up is addressing each component separately, and your top down is using the occupation to address the components. So in that bottom up context, the treatment session I just described for lower body dressing with the warm up for core stability, and then the crossing midline, and then the stretches, and then whatever. So each component I'm addressing separately to then do the final task, versus top down where I'm doing all of that with the pants in their hands in the moment. Be mindful of what a passive versus active activities are. Passive being you do all the work, and active, you're actively engaging the client. So, how do you make passive activities more active? So range of motion, like passive range of motion, e-stim, education, those can all be very passive activities, but how do you make them engaging so that the client is an active participant in the activity? and in the treatment session. So you have your different treatment approaches, become familiar with these. These will help you frame why you're doing what you're doing within the treatment session. Think about the prep methods, the preparatory methods and tasks, your interventions to support occupation. How do you sort of warm up the client to do what you want them to do? Choosing wisely, go to it, read these, I love them. And always consider grading and adapting. This starts with your evaluation. So for example, transitioning from supine to sit. I'm going to lay the bed flat first. I'm going to lay the bed flat first to see if the client is able to transition supine to sit. They are not. Well, maybe now I will introduce some sort of manual physical cue. I've just graded it down. Still client unable to transition supine to sit from a flat surface. So now I raise the head of the bed up. So I'm grading that activity down, down, down until the client is finally able to do the task. Lower body dressing, I give them the pants and they're at seated level and they're zoop, 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 able to do it. Grading up, I now introduce the pants in standing. So always thinking how to make the activity more challenging if the client is able to do it, and how to make the activity less challenging if the client is unable to do it. And if it's a complete flop, how do you adapt it and how do you help with compensatory strategies? So think hemi-dressing and activities such as that, so that they're able to actively engage in the activity. And always think, why are you doing what you're doing? Everything comes from a place of evidence and with your frames of reference. So I go into every interaction knowing that I'm looking at the person, the environment, and the occupation, and how they all work together for how all of those components work together in the client's abilities. So then I'm modifying the environment, or I'm modifying the occupation, or I'm, engaging the person into the activity. So that's the frame of reference that I use primarily, the PEO. And I'm always coming from a place of evidence. I'm always using up-to-date research to shape why I'm doing what I'm doing. I'm not using out-of-date methods that have been proven not to have any efficacy. So all those occupational profiles and all those occupation-based activities analyses have led you up to this moment of documentation. Now, going forward, you will continue to see some of those AOTA templates, the occupation-based or occupational profile templates. You'll be asked to do them, but now you're doing them with more confidence, but also now you're able to create your you're able to create your interview, you're able to create your evaluation based on the occupational profile, based on now how you are able to analyze your client, how you're able to evaluate them. So you'll be able to put all of that together without maybe the use of that template. But if you find that it's helpful, please go ahead and use it. But also, how can you pull pieces out of that as you go through and do your work with your clients? So I hope this was helpful. Please don't hesitate to reach out to us if you have further questions, but know that we will continue to work on this throughout your time here, and in your final semester you will have a whole class that will go through every single step of this. So have a great rest of your day.